Good morning, doctor and everyone else that's watching. Today, my group and I are going to present to you about the prevalence of binocular vision dysfunction of patients attending the optometry clinic from 2000 to 2017. This is our proposal presentation. Okay, here are my group members. You can put my name. Right now, I'm going to tell you a bit of the introduction for our topic. Accommodative and non-strabismic binocular dysfunctions are often encountered in our optometric practice, and so we did some reading on this topic and found these are some of the results that we found. Okay. Laura et al. In 2001 found that accommodative excess is more prevalent than accommodative insufficiency, and the same goes for convergence excess, which is more prevalent than convergence insufficiency. Although there are other studies that showed accommodative insufficiency to be more prevalent. Okay, Martinez et al. In 2009, they found that vision therapy improved symptoms and signs of convergence insufficiency. And Panetta et al. In 2015, which is quite recent, they did their research in a pediatric Puerto Rican population, and they found that accommodative and non-strabismic binocular vision problems are quite prevalent. So at the end of their paper, their research, they strongly suggest that an appropriate vision evaluation, diagnosis, and treatment is important to improve the quality of life of this pediatric population. Okay, these are our problem statements. According to the researchers that we found a lot on Western population, and there's only one on South Korean population. So there's a limited research on the prevalence of binocular vision dysfunctions in Malaysia. Even in Southeast Asia, the research is limited. And patients with binocular vision dysfunction will have difficulty during their work. And the last one is lack of uniformity in diagnostic criteria that cause differences in the prevalence result. Then, if we have a better understanding of these binocular vision dysfunctions, it will allow us to recommend suitable treatments for these patients and the standardization of binocular vision dysfunctions diagnostic criteria when we encounter them in clinic. This is our conceptual framework where binocular vision dysfunction can be caused by network demand or individual work factors, which is further divided into age and uncorrected refractive error.
Okay, Assalamualaikum. Saya Syamil. I will talk about literature review. Okay. First, actually there have been studies that found the prevalence of binocular dysfunction in various populations, clinical, pediatrics, and even presbyopic people. The binocular dysfunction that are commonly studied are accommodative dysfunction and binocular dysfunction. Okay. In 1983, Dow has conducted a study suggested that the most prevalent binocular dysfunction is accommodative insufficiency. However, the prevalence of binocular dysfunction among university students has been conducted by Foca and Martinez Palomera in 1997. They found that accommodative excess is the most prevalent binocular dysfunction among university students, which equivalent to 10.8%. Okay, this result was supported by a study performed by Lara et al. In 2001, which the accommodative excess is more prevalent in the clinical population compared to the accommodative insufficiency with 6.4% and 3% respectively. The result of this study vary because of the population taken in each study and the method how to classify the binocular dysfunction itself. There was no mention of divergence dysfunction in this paper, suggesting the rarity of these problems in a clinical population. Despite the difference of results between studies, it was evident that non-strabismic binocular dysfunction occur in the general clinical population. It is by full assessment, as written by Lara, will ensure that such disorders do not go unnoticed in the routine eye examination. The study also includes convergence dysfunction, as suggested by Lara et al. In 2001. Convergence excess is more prevalent compared to other convergence dysfunction, with 12 out of 265 subjects have this problem. They also found that only 2 out of 265 subjects have convergence insufficiency. Okay. For the treatment are given to the patient in order to reduce the signs and symptoms that are complained by the patient, such as astigmatism, difficulty when reading, diplopia, headache, and so on. There are a lot of treatment available to the patient who have binocular vision dysfunction. An example for the treatment are vision therapy, plus lenses, prescription of refractive error, prism, and more. However, not all the treatment are effective to the certain type of binocular vision dysfunction. According to Wire and Wick 1995, prescription of the refractive error for 1 to 3 months will be effective for those patients who have binocular dysfunction, such as accommodative and convergence problem. This study was supported by Martinez et al. At 2009, which state that correction of the refractive error is a treatment option for accommodative access and accommodative facility. Meanwhile, based on Martinez et al., the treatment that is suitable for convergence access and divergence access are prescription of refractive error followed by vision therapy. Okay. According to Galloway and Scheinman in 1997, therapy for convergence access include office-based visual therapy and home-based complementary therapy, tonic and basic training of NMV accommodative block for a duration of about 4 weeks. As for convergence insufficiency, vision therapy for 12 weeks are the most widely used treatment, followed by pencil push-up for 6 weeks and base-in for 6 weeks with a prescription of refractive error. Scheinman et al. In 2005 state that with pencil push-up treatment is not effective for achieving clinical significant improvement in symptoms or signs associated with convergence insufficiency in young adults. However, use of the plus lenses is more noteworthy compared to the use of vision therapy and prescription of refractive.
Assalamualaikum. Okay, I'm Shoda. Now we move on to the research questions. Our research question is, what is the prevalence of the binocular vision dysfunctions among the patients attending UKM Optometry Clinic from 2000 until 2017? Okay, research objective. We have two research objectives, which is to identify types of binocular vision dysfunction recorded among patients attending Optometry Clinic UKM from 2000 to 2017. And then second one is to identify types of treatments given to the binocular vision dysfunction patient attending to Optometry Clinic UKM from 2000 until 2017. Okay, for the hypothesis, we state that there is a significant difference in the prevalence of the types of binocular vision dysfunction based on the clinical assessment. And for the clinical assessment, we focus on the amplitude of accommodations, near point of convergence, monocular estimation method, accommodative facility, heterophoria, accommodative convergent accommodation, which is ACA ratio. Okay, then for the criteria, for the inclusion, we include the age from 7 years old to 39 years old, and also the patient that have corrected effective error. And exclusion, we exclude the patient that is presbyope, low vision, that have systemic disease, ocular disease, and also strabismus.
Assalamualaikum, saya Fatin. Seterusnya kita tengok kepada metodologi kajian. Bagi kajian kami pada kali ini, kita gunakan research design adalah retrospektif, di mana kita akan melihat balik data-data yang dalam file klinik, dan daripada situ kita akan classify untuk cari prevalence. Dan seterusnya sources of data adalah dikumpul pada tahun 2000 hingga 2017 berdasarkan file di klinik Optometry UKM, dan research population yang kita fokuskan adalah semua patient yang datang ke UKM Optometry Clinic, dan dia punya sampling frame adalah patient yang berumur 7 tahun hingga 39 tahun. Kenapa kita ambil 7 tahun? Kita sebenarnya nak pada umur 7 tahun tu patient sudah datang ke klinik dengan untuk cek mata dengan simptom, dan 39 tahun adalah umur sebelum presbyope. Dan sampling unit kita guna patient yang diagnosed with binocular vision dysfunction, di mana kita tengok file tu kita ambil patient yang dah didiagnose dengan binocular vision dysfunction yang general sahaja. method adalah kita guna stratified sampling method. Stratified sampling method di mana kita akan bagikan file kepada beberapa grup yang dipanggil strata, dan kita akan numbering. Kita akan nomborkan grup tu dan kita akan pick secara random. Untuk stratified sampling method ni, apa kebaikan dia? Dia lebih tepat, lebih accurate sampel, dan juga dia boleh digunakan untuk proportional dan juga non-proportional sampel. Seterusnya adalah sample calculation. Kami menggunakan formula by Daniel dengan estimate population proportion. Ni formula dia, N is equal to Z. Z is the level of confidence. P adalah expected prevalence, dan delta. Okey, daripada Z, nilai Z kami gunakan 1.96, iaitu 95% confidence level. Dan pengiraan kami bahagikan kepada grup. So setiap types of binocular vision dysfunction kami kirakan sample size. Okey, daripada ni ada 4 types of binocular dysfunction. So daripada setiap kategori ini kami total up dan sebanyak minimum 218 sample size.
Assalamualaikum warahmatullahi wabarakatuh. Saya Farida binti Muhammad Ghazali. Seterusnya kita pergi kepada analisis kajian. Okey, kaedah kajian yang kami gunakan untuk mencapai objektif yang pertama iaitu identify type of binocular vision dysfunction berdasarkan peratusan. Jadi berdasarkan peratusan file data-data yang kita kumpulkan daripada klinik di bawah, kita akan melihat kepada capaian untuk mencapai objektif pertama. Sama juga dengan objektif kedua, kita menggunakan kaedah kajian iaitu peratusan. Okey, jadi untuk research kali ini kita akan menggunakan beberapa prosedur, beberapa kaedah. Yang pertama, kita akan melihat data-data itu, kita akan ada inclusion dan exclusion yang telah dibentangkan tadi. Seterusnya daripada inclusion dan exclusion tadi, kita akan turun kepada klinik dan melihat file-file tersebut. Kita akan melakukan certified random data, which is dengan kita mengambil file-file tersebut dan kita akan groupingkan mereka. Daripada grup tu kita akan pick randomly file-file pesakit sebanyak 218. Itu adalah minimum. Seterusnya daripada file-file tersebut kita akan collect data, dan daripada data-data yang dikumpulkan kita akan analyze menggunakan SPSS. Seterusnya kita akan membuat sedikit discussion berdasarkan data-data yang telah dikumpulkan, dan dia compilekan menjadi dokumen, dan seterusnya akan ada yang terakhir adalah final conclusion lah berdasarkan pencapaian untuk mencapai 2 objektif sebentar tadi. Okey, ini adalah gancet kami. Sekarang ini kita berada di minggu 20 hari bulan 3, iaitu proposal presentation. Seterusnya kita akan membuat data collection, data analysis, dan kita akan buat research presentation pada minggu yang ke-18 hari bulan 5. Okay, ini adalah differences. Terima kasih.